It is truly an honor for me to introduce our next esteemed speaker, Dr. Adam Rapoport. Dr. Adam Rapoport is a dedicated pediatric palliative care physician at Sikh Hospital in Toronto and the medical director of the Pediatric Advanced Care Team, PACT. I was lucky enough to see him in action while I was doing my fellowship over there. So through his compassionate approach and deep expertise, he has profoundly impacted the lives of children with serious illness and their families, ensuring that care extends beyond treatment to dignity, comfort, and quality of life. Beyond his clinical work, Dr. Rapoport is also an educator, leader, and advocate for advancing pediatric palliative care, both in Canada and beyond. So Adam, I'm so happy that you were able to join us today, and welcome.
Thank you, Adi. Thanks for that really nice introduction. And I want to thank all of you in PsyOp Europe for the opportunity to speak today. All right, as far as objectives go for today's lecture, it is my hope that by the end of this talk, you're going to be familiar with some of the benefits of palliative care for children with cancer and their families, if you're not already familiar with that. I'm hoping that you're going to recognize the two greatest barriers to palliative care. There are lots of barriers that we'll talk about, but I think they all collapse down to two primary things. And finally, I'm hoping by the end of today, you're going to understand why the best way to transition your patients to palliative care in oncology is to avoid having to transition them at all. Let's start by taking stock. You have reached the end of your 2-day course, and you have already learned so much. I took a look at the program. You had some really terrific speakers from across the world, and they have demonstrated to you that palliative care can help with physical suffering, help with communication with children about life and death, that it helps support spiritual and cultural needs during serious illness, can help achieve high quality end-of-life care at home, engage in advanced care planning, psychological support for both the patient and the entire family, and of course, provide bereavement care. And I think it's important to note that you've learned a lot of these skills as well, so that you don't just need palliative care experts to do this. These are things that you can do directly with your patients and families. Judging by this, one would think that you're all ready to introduce palliative care to most of your patients and families. Time to make routine referrals, right? Well, in fact, if we look at the literature, it sort of shows a bit of another story. Things are definitely improving in this area, but a recent systematic analysis looking at referral rates in pediatric palliative care, specifically in children's oncology, demonstrate that almost half of children with cancer who die never get referred to palliative care services. Now, some of you are probably thinking, okay, but not every child needs to be referred to palliative care, and I completely agree with that. There are children who die from treatment-related mortality causes, but in fact, there's been a number of studies that show that the vast majority of children who die from cancer in 2025 are still dying as the result of progressive disease. We can see it coming. And I think that that's the group that we should really be targeting for the intervention of palliative care. It is clear that palliative care integration for children with cancer and their families can have lots of benefits. And again, I'm hoping you've learned about this over the course of the last 2 days. But just to solidify things, I want to highlight a couple things, a few things that we know. And I'm actually going to pause here to mention that everything in this presentation, you'll be provided with references. Sometimes on the screen, you'll see numbers. At the end of the slide, you'll see numbered references. This particular slide has no references about the impacts of palliative care in pediatric oncology. And the reason is I have a whole other unique slide just on this topic, and you'll see a lot of references. We know that palliative care integration for children with cancer can lead to decreased pain and other symptoms, that it can increase the child's quality of life as rated by their parents, that there is an increased chance that the child, if they do need end-of-life care, will be able to die at home or in hospice, that there are higher rates of advanced care planning, which in and of itself, I would say, is a beneficial thing. There are a number of studies that show, regardless of what happens as an outcome of advanced care planning, simply giving children and families an opportunity to think ahead about what matters most to them can be an invaluable experience. But if that weren't enough, we know that patients who go through advanced care planning and families who do engage in this process have higher rates of decisions to put a DNR on the chart, and sure enough, lower rates of resuscitation attempts when they need end-of-life care. Going beyond just resuscitation, there have been a number of studies, some of which I've been involved with in my province of Ontario, that demonstrate that when palliative care is integrated into the lives of children with cancer, we see higher intensity end-of-life care. And these are things that are often defined universally in multiple studies around the world as death in the ICU, mechanical ventilation at the time of death, multiple admissions or emergency department visits, things like IV chemotherapy, in the last 2 weeks of life. We know that when palliative care is integrated, we see less of this. As if these things weren't enough, there is clear evidence to demonstrate that integrating palliative care lowers the costs of medical care. Perhaps not the most important thing, but something that we have to recognize. We are always dealing with finite resources and that we are stewards of those resources and we should be mindful of. And last, and perhaps most importantly, increase family satisfaction overall. So lots of good reasons to integrate palliative care into the lives of your patients and families. And not surprisingly, with all these good reasons, we have seen wide endorsement of early palliative care integration, not just from PSYOP, which is why you're all here, but from all these reputable international groups that think about these things. So the question we need to ask ourselves, and that I want to focus in on together with you today, is why is there such a big gap? Why are we seeing this gap between what the evidence shows us we should be doing, which is getting palliative care involved and integrating it into the lives of your children, your patients, and their families? Or another way of asking it, why are the barriers to involving palliative care, or what, are the barriers to involving palliative care in pediatric oncology? Because something is getting in the way of doing this. And actually, I want your help here, if it's okay. I'm going to ask you to pull your phones out, scan that QR code, and just type a few things. Of course, the shorter the answer, the better for this kind of thing. You can do one words or a couple words. But what do you think are the barriers to involving palliative care in pediatric oncology? If you can't scan, you can go to slido.com and it'll ask you to put a number in, and you can do so. Just put that number there. But I'd love to know what your thoughts are. What do you think are some of the biggest barriers to integrating palliative care? Not available. That's a big problem. Fear. The primary oncologist is the one getting in the way. Avocado syndrome. I'm not familiar with that. I want to hear about that. Maybe someone can type that up later. Lots of things. Feeling of failure, biases, lack of training, funding, scary term for sure. We're going to talk about that. Stigma. Yep. Lots of great things here. Terrific. As I mentioned in the objectives, I think other than the lack of access, which maybe we can talk about in the Q&A about how to deal with, I think a lot of these things collapse into two things. One of them is this. Clearly, we have a bit of an image problem in pediatric palliative care. I think that a lot of people associate palliative care with death and dying, and that was that fear aspect that came up so much. When you ask most people what is palliative care, and this is true of healthcare providers or just people on the street, if they know what palliative care is, they describe it as looking something like this, that a patient gets a diagnosis of a serious illness. There's often a period of active care where we're trying to fight or cure the disease, but at some point we reach sort of a transition period. And on this image, it's where the dark gray box starts. And that's often when we integrate palliative care. It occurs for a bit of a time. There's hopefully some relief of symptoms and suffering, some addressing of psychological distress, maybe the patient's at home, and then eventually death occurs. Well, is this true? Does palliative care actually look like death and dying? I think it does in that image. It's something that starts just before it. Well, in fact, when we look at the literature, and this is the most recent literature that I could find, guys, it is true that many oncology patients receive palliative care in the last days of life or not at all. This is a systematic review of adults, and again, you'll have all the references at the end of this. It showed that the median time between palliative care referral, the initial referral to a palliative care service, and death of the patient, just 19 days. In pediatrics, I'm proud to say we're doing a lot better, median of 86 days. But keep in mind, that's 3 months before the death of the patient. And when we factor in this systematic review for children looked at the mean time between the initial diagnosis and palliative care referral, it's about 510 days. So again, relatively speaking, palliative care is introduced pretty late in the disease course. So if we're answering the question, does palliative care equal death? I would say to you that for most people, the answer is yes. And so there's no wonder if you were to tap somebody on the street, wherever you are right now, and say, do you know anything about palliative care? If they do, they would probably say yes. That was the doctor or the team or the nurse that got involved, days or weeks just before someone in my life died. And so for most of the public, palliative care does look like death and dying. We're going to talk a little bit today about ways to change that. There are certainly things that palliative care teams can do to make that better. But given that this is an oncology lecture, and most of you, I think, if not all of you, work in pediatric oncology, our primary focus today is going to be about things that you can do to help with that perception. I see things are in the chat. If it's okay, we're going to save that till the end. Oops, let's continue. I'm going to give you a quick history lesson about palliative care because things have evolved over the years like they have in all fields. And I think that this is part of the reason why palliative care is still very much associated with death and dying. And I think this may in part answer the question that was posted in the chat. I often think of palliative care as maturing or evolving in 3 phases. And there is no doubt that phase 1 of palliative care started with a focus on death and dying. We're going to cover the period first, leading up to about the Second World War. Prior to that, let's say, to the 20th century, just to be safe, death was a very different beast than what we know today. Most people were not dying in hospitals. In fact, if a patient was recognized to be nearing the end of their life, that's usually when physicians or hospitals said, there is nothing left that we have to offer. Time to go home, be with your family, and focus on being together. Death was actually the realm of families and sometimes spiritual care providers like the church or other people that would be in the home to help ease patients into their death and dying. Death was not something that we were seeing in the hospital setting. But as society started to shift, as the Industrial Revolution occurred, there were changes in the social fabric. Fewer and fewer patients had families to be with. Not everybody was living in the same household for generations. More and more people were going to work, and so were not able to care for their loved ones at the end of life. And there was an individual that recognized this. Her name was Dame Cicely Saunders. Cicely Saunders is largely credited as being sort of the founder of the modern hospice palliative care movement. Cicely Saunders recognized that there were a lot of people dying in the UK, which is where she lived, that had no place to go and no one to care for them. And she opened up the very first modern hospice called St. Christopher's in 1967. Saunders was a nurse. She also had a degree in social work, but she went back to school to become a physician. And she learned that there was actually a lot that we could do at this time to help ease the suffering of patients who were dying. She opened up St. Christopher's as a place where patients could go that were nearing the end of her life. And that's where we attribute, that's sort of where we think of our modern roots as growing out of in palliative care, very squarely focused on death and dying. Let's fast forward to the next phase of palliative care, which I attribute to as occurring in about the 1980s. And this part of our story actually has a very Canadian slant to it, which I'm very proud of as a Canadian myself. In the 1980s, there was a urology fellow that was training in Montreal. And by this point, he had recognized that things had really changed since before the time of Cicely Saunders. If prior to Cicely Saunders, there were very few patients dying in hospital, most were at home, in the 1980s, this physician named Balfour Mount, a urologist in Montreal, had recognized now the wards in hospitals in Western society were filled with dying patients. He actually described that they would go from rounds in the morning and they'd go room to room. And some patients, they would talk about the surgical procedures they were going to perform this day or the after surgical care that they needed to give, looking at ins and outs. And then they'd go to the next room where everybody would recognize this patient was dying, usually due to a urologic cancer of some sort. They would all look at one another, sort of put their heads down, and then move to the next room because they had nothing to offer these patients. Well, Balfour Mount said there has to be a better way. There's got to be something that we can do. And he actually looked and found Cicely Saunders. He traveled across the pond and he did a fellowship with her. He had to convince her to take him on, but he worked at St. Christopher's Hospice and learned all about this hospice movement that Cicely Saunders had developed. By the end of his training, Balfour Mount said, "This is something that I need to hang on to, but we need to expand it." You see, Saunders' hospice movement was a bit of a fringe movement. It was happening outside of the big tent of academic medicine, right, which was occurring in the hospitals. She was doing it in this little sideshow in London. And Balfour Mount said, this is a problem now in the hospitals. It's everywhere. We need to somehow bring this type of care under the umbrella of modern academic medicine. We got to bring it inside the tent now. And in order to do so, he said we have to shift away from a focus on death and dying because that's something that people don't want to talk about and don't want to focus on. We're going to focus it more on relief of suffering. And he actually coined the term palliative care from the Latin word palliare, which means to cloak, because we were either cloaking the symptoms, hiding them, or another reason for it is that palliative care walks with people who are suffering. A cloak is also a cape, and there are images of wrapping your cloak around somebody. And so that's what Balfour Mount did. He coined the term palliative care. He said that we are going to move it from outside of as a fringe movement more to inside under the big tent of hospital and academic medicine, and our focus is going to be on suffering. Well, we know how well that went with his change in terminology because, of course, as we already just talked about, everybody still associates palliative care with death and dying. But the field has moved away from that second phase, and now we're clearly in a phase where palliative care is focused on quality of life. It is now recognized that there are many more patients than those who are just dying that are suffering as a result of their serious illness. And palliative care has something to offer. The focus now is on integrating palliative care and making sure that every day is as good as possible. And just to give you an example, when I look at the stats on my patients at Sick Kids, we break things down into end-of-life care referrals and supportive care. And in 2024, I just crunched the numbers. 90% of the patients that were referred to my team were for supportive care. 10% of patients only were for end-of-life care. Don't believe me? Here's the modern definition today from the Center for Advancing Palliative Care. Palliative care is specialized medical care for people with serious illnesses. It's focused on providing patients with relief from the symptoms, pain, and stress of a serious illness, whatever the diagnosis. The goal is to improve quality of life for both the patient and the family. Notice the word that's missing in this definition. No mention of death, no mention of dying. I want to offer, though, that while death is still a big focus of palliative care and a big part of the barrier, which again is a misconception, I want to put out there that there is another big barrier, and that I think is captured really nicely by this image. For most of your patients and families, thinking about palliative care looks to them like they're standing at a bit of a crossroads and they have a decision to make. So do you as pediatric oncologists. The patient can go to the right or to the left. Let's start with the right, the bright side where the sun is there, the clear, bright path. This is the path of, more chemotherapy. This is the path of going for a bone marrow transplant or CAR T cell or even experimental therapy. This is the path of hope. The other option is to choose palliative care, to recognize what's happening, acknowledge that this is the case, accept palliative care, maybe make your child more comfortable, have some time at home, but this is a very stark and difficult choice to make. And this is when this sort of idea really solidified for me. This was a landmark study that came out in 2011, and it was published by lots of my colleagues at Sick Kids who work in the division of pediatric oncology. This is actually a national study, and this made headlines when it came out. Look at the title of this study: Chemotherapy versus Supportive Care Alone in Pediatric Palliative Care for Cancer. Can you see that sort of bifurcation? And here was the justification for the study in the background. When cure becomes unlikely, parents and healthcare providers are often faced with the decision to continue further aggressive treatments or to provide relief from symptoms alone. Look at that stark difference. Here's what they did in the study. They took parents whose children actually had advanced cancer and were likely going to die, and they asked these parents about a hypothetical scenario. They felt that it would be too difficult to talk about their own child, but they wanted parents that were actually thinking about these things. And so they took parents with children with advanced cancer and they said, read this hypothetical scenario about a child that has a less than 5% chance of survival. Imagine now that you were their parent and you were faced with a choice to continue giving chemotherapy. And in this example, it was IV chemotherapy, and it was explained. It was not for curative purposes. It was experimental in nature. You could go for the IV chemotherapy, or you could accept palliative care. And they asked them, what would you choose? They also asked a group of oncology healthcare providers, including physicians, nurses, and social workers. And look what they found. Significantly more parents, again, that number 54.5, compared with healthcare providers, favored the chemotherapy, even knowing that the chemotherapy was not meant to help their children, even being told that it would require them to come in a hospital and it would likely cause side effects. The majority of parents chose to go with the chemotherapy. Why? Well, the authors offered a reason, and I think they're exactly right. Because of hope. The bottom line is that families want hope. And I got to tell you, I think if I was in the position of those families, I would choose the same thing. I think it's the same reason why occasionally I buy a lottery ticket. I know in my heart I'm not going to win that lottery, but, why not? Someone's got to win that lottery. Why couldn't it be me? And I think that that's why so many parents continue to, move in this direction as well. They might know in their heart that that chemo is not meant to help their child, is unlikely going to work, may even come with suffering, but that's the side to them that brings hope. And for some reason, the option of palliative care is often seen to them as the absence of hope. We need to change that, guys. You need to change that as well. We need to go from this image of palliative care and hope being completely separate to this situation. We need to take the choice out of it. We need to make sure that families know that we can keep fighting the cancer. We can go forward with CAR T cell therapy or bone marrow transplant. We can even look at experimental therapy, and we can make sure that their child's quality of life is being attended to, that suffering is being addressed, whether that's physical or emotional suffering, and that we can give optimal support to the whole family. Why should we wait for the final days or weeks of life for a child with cancer to be comfortable when we can make sure that their comfort is being addressed from day one of a serious diagnosis? The key here is early integration of palliative care. Let's talk for a minute about why early integration makes sense. Well, first of all, it increases the likelihood that physicians, clinicians like me, are actually going to be able to improve quality of life, not just the quality of death of patients. When I meet patients in the final days or weeks or even months of life, I'm usually focusing my efforts on symptom management, talking about difficult things, and getting them where they want to be. But when I get integrated earlier, I'm incorporating massage therapy, music therapy. I'm making great things happen. I'm often helping patients and families live their best life while they're going through cancer treatment. Integration of palliative care early allows for a trusting relationship between the palliative care team and the patient and family to develop. And that can be really important if this patient and family is going to move towards end of life. You, as oncologists, often want us to be very involved at the end of life. But if patients and families don't trust us, if we're just a group of strangers, it's really hard to make that happen. But if palliative care is integrated early, we build a relationship over time, and there's no transition at all, as I mentioned. It facilitates the process of advanced care planning. There's lots of great literature that advanced care planning is not something that should occur on a single occasion. It's best when it occurs over time with a team that you have a good relationship with. And advanced care planning is based on lived experience. As the child's disease changes, as the family's experience changes, they're more likely to start thinking differently about things, and we can engage in that over time. But the main reason why early integration makes sense, in my opinion, it is the best way to overcome those barriers to pediatric palliative care involvement. If the major barriers are the focus is on death and dying, and the focus is that it leads to a lack of hope, well, then integrate palliative care when nobody is thinking about death and dying, when cure is the option right now, and that's what we're going on. That is the best way to actually overcome those barriers when there is still hope. It gives a clear message that we're not bringing in palliative care because there's no hope. We're actually very hopeful, and still this team has something to add. When should you consider referral? Well, these are some of the common patient-family issues that are often used. When they're suffering due to uncontrolled symptoms or difficult to treat symptoms, when you notice that your families are finding it hard to cope, when there are concerns about the child or the family's overall quality of life, maybe there's difficult decisions that are being made, or when some families are starting to think about the what ifs. What if this doesn't work? What if things start to get worse? I also want to mention that it's not just when the families are showing these things or asking these things to you, but also when you're concerned about any of the above. When you're in doubt, if when you have some doubt that maybe these families of yours are struggling, you should ask about it. I promise you, your families are going to appreciate it if you highlight these things and say things like, I've noticed that maybe you're having a hard time with this. I think that there's a team that can help us with this. What do you think? Let's take 1 minute to talk about the issues regarding automatic referrals, or sometimes these are called triggers to integrate palliative care. I want to say that these can be a really good facilitator to involving palliative care. And the reason is that triggers or some kind of specific thing that leads to an automatic referral removes the subjectivity involved. And so we do see improvement. Here are some of the common triggers that are often used. If the diagnosis carries a high risk, like diffuse intrinsic pontine gliomas, if there is a poor prognosis, like a relapse or severe metastatic disease, difficult symptoms to manage, difficult treatment course, like ICU admissions, or complex psychosocial needs. All of these things have been listed in the literature before as triggers that can be used by oncologists to integrate palliative care. I do want to say that any triggers that are developed should be done together with oncology and your palliative care service. It can't just come from one group, and it certainly can't come from palliative care experts like me. It has to be something that's agreed upon. And a warning, and this is an interesting study, study number 11, that I encourage you to look at, which again is in the references. Triggers can be circumvented. In this study that involved a group of oncologists, the vast majority endorsed using these triggers here to refer their patients. But then what the researchers did is they gave the same oncologists that agreed to these triggers hypothetical scenarios. And they said, in these situations, what would you do? Refer your patient to palliative care or not? And many of them didn't recognize the very triggers that they endorsed. And so again, triggers are good, but they need to be worked on and they need to be pretty specific. So last but not least, how do you actually introduce palliative care? My advice to you is to focus on quality of life. Here's some of the language that I recommend. Cancer or hard to treat cancer always has an impact on a child and family's quality of life. We have a team that helps ensure that while we're doing our best to treat your child's cancer, your whole family is living their best life possible. Taking the choice out of it, doing these things together, integrating them. When you introduce palliative care like this, I promise you, this is something that every child and every family wants. Nobody puts up a fight to this kind of thing. I also recommend that you address misconceptions. If your palliative care service goes by palliative care, and we can talk about that in the Q&A, that's an interesting subject. Or if they go by my team's name, things like the PACT team, I often encourage oncologists to say, have you ever heard of PACT? Or have you heard of the palliative care team? Address those misconceptions right on. They're about helping patients and families live better. Palliative care today is about living, not about dying, and it's at any stage of a disease. One last thing I wanted to address. Some of you might be thinking, especially after this 2-day course and you've learned a lot of great skill sets, can't I just deliver palliative care to my patients? And the answer is absolutely. Remember, all children with serious illness should have an integrated palliative care approach. And so all of you need to be skilled at integrating palliative care, making sure that while you're treating your patient's cancer, you are addressing quality of life, you are focusing on the symptoms, and you're helping your patients live their best life. But I really encourage you to think of palliative care similar to how we think about infectious disease or psychiatry as pediatricians. Every pediatrician needs to be adept at doing a workup on a patient that has a fever or a rash or some kind of suspected infection. We all have to know when to treat with antibiotics and how to do certain cultures. But we know for more difficult cases that we pull in our infectious disease colleagues. Same thing with behavioral issues. Every pediatrician needs to be fairly adept at managing certain behavioral problems. But when things get difficult, that's when we involve our psychology experts or our psychiatry experts. Same thing with palliative care. So, yes, you have something to do in palliative care and you can deliver it to your patients, but I want you to consider that you are unfortunately burdened with time constraints. Most of your patients are going to do well. We have really good data with that, and they need your attention too. Palliative care colleagues can unload that burden and work together with you. You have limited training and education in palliative care. It's terrific that you're doing courses like this, and I encourage you to keep learning more, but it's not something that you're doing day in and day out. And so you need to recognize that there are others who have better education and training and potentially can give better care to your patients. Remember that many of you as oncologists lack the ability to provide care in other locations, like home, which is hopefully where most of your patients are, or sometimes hospice. And the bottom line is that there are a number of studies that show that pediatric palliative care is best provided by specialists on an interprofessional team. These studies here compare specialty pediatric palliative care outcomes versus generalist palliative care. And that basically means oncologists who are delivering palliative care to their patients. There are clear advantages in some cases to integrating specialty palliative care. So I want to end with just a couple summary and suggestions for you, and then we'll have a few minutes for questions. My first recommendation for you is break that cycle. Late referral leads to palliative care being introduced near the time of death, which then leads to further reluctance to refer patients more because you're worried about fear and what it means, and you're in this vicious cycle. You need to break that cycle. The greatest barriers to palliative care involvement are the misconceptions that patients have that it's only about death and dying, and the current referral patterns that reinforce that misconception. And most importantly, we need to stop making families make that impossible choice of deciding between hope and quality of life, hope and comfort. By integrating palliative care early, we know that it leads to positive outcomes and benefits for patients and families. And in fact, I would argue it is the single best way to overcome those barriers that we talked about today. These are the references. These are specifically the references to early integration, which are different from the other slide.